Okay, I think we can go ahead and get started. Welcome to today's Grants and Sponsored Research Initiative seminar hosted by the Research Program on Children in Adversity at the Boston College School of Social Work. My name is Dr. Jordan Fair, and I'm the Associate Director of Research at the RPCA. This seminar series was founded as part of the U19 Youth Forward Implementation Science Hub, funded by the National Institute of Mental Health and their global network of U19 scale-up hubs. Our other partners in this work include the Essence and Shine U19 hubs and the University of Rwanda Center for Mental Health. I would like to also announce that the RPCA is hiring for multiple positions. So if you are interested in getting involved with the lab, please visit our website or contact Tesla Abrego for more information. And now I am pleased to introduce today's Grit Speaker seminar, or Grit Speaker, Dr. Rohit Ramaswamy. We are especially fortunate as Dr. Ramaswamy is part of the Essence Hub, so a real treat for us today. Dr. Rohit Ramaswamy is the Associate Director of the Public Health Leadership Program and a professor in maternal and child health at the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. He is also the co-director of the UNC RTI Consortium for Implementation Science. Dr. Ramaswamy's area of expertise is applied implementation and improvement science, which deals with the development and evaluation of systematic methods and tools to sustainably implement and improve complex interventions. His work blends the tools of system science, design thinking, implementation science, and continuous quality improvement to build capacity for implementation. His global projects include the improvement of clinical and operational processes in tertiary maternity hospitals in Ghana, developing the quality improvement capability of district-level government staff in Kenya, and integrating mental health service delivery into the district primary healthcare system in India. Today, Dr. Ramaswamy will present on theory-based implementation and evaluation of complex interventions, experiences from Ghana. We're so grateful to have you with us today. Thank you very much, Dr. Ramaswamy, and I will turn it over to you. Oh, you are muted.
Okay, can people hear me? Much better.
Much better.
Thank you, Jordan. Pleasure to be here today. And as Jordan said, a lot of the work that I do is in Ghana, and that's the context in which I'm going to be talking about today. So let me start sharing my slides. Let's see. Can people see my slides? I'm going to go to sleep.
Yes.
Okay, as Jordan mentioned, a lot of the work that I do is at the intersection of implementation, research, and practice. And so the challenges that we have as implementation practitioners trying to bring implementation science into the field is, on one hand, we have to be cognizant of the fact that we are working in field settings, that we don't have often the opportunity to bring a carefully designed research program into these field settings. We have to be cognizant of the fact that we're working in environments where everyday program implementation or patient care is taking place. And yet we want to make sure that we are bringing the most systematic way of thinking about implementation science. In other words, we're bringing the science of implementation into the work that we do. And so what I'm going to talk about today is our experiences over almost a decade of work in Ghana in tertiary maternal hospitals. And I'm going to talk about how our thinking has evolved around how do we bring systematic way of thinking about implementation science theories and their application to these real life settings. A lot of what I'm going to be describing is work in progress. And so very much kind of in the spirit of learning as we go, as we have been working in these settings, as we have been engaging with the frontline staff, as we have begun to learn more about implementation, our use of implementation science tools and methods has become more rigorous. And so what I'm hoping that I will share with you today is kind of our own journey and how we have been thinking about doing rigorous implementation science in practice-based settings, and use this as an opportunity to open it up for questions that all of you might have around work that you're doing, similar work that you're doing. My talk today is intended to be for about half an hour, 30 or 35 minutes, so I've not kept it super long. That'll give us the opportunity for us to have a discussion at the end of my presentation. So what I'm actually going to do is I'm going to start with talking about the program that we have been working on, but then I will step back a little bit and talk about implementation theories in general, and then come back to the application of some of these theories to this work. So the context of within which I'm going to talk about today is improving care for high-risk mothers and newborns in referral hospitals in Ghana. These referral hospitals are tertiary hospitals, and they are the hospitals where often the sickest mothers and babies are referred to. And so these are the places where most of the high-risk cases land up. Ghana, like a lot of other countries, has made tremendous strides in reducing maternal mortality. And they've done that by strengthening the quality of health systems and health and hospitals at the lower levels, and by strengthening referral processes where they can identify mothers who are at high risk and then send them up to the tertiary hospitals. But what has happened, of course, is that as a result of that, there has been a bottleneck in the tertiary hospitals. These hospitals they are obviously better equipped and better resourced and have better trained and specialist staff than the lower level hospitals, which is why they see the higher risk patients. But by the same token, because they get a lot of cases, they have high work volumes. They're still, even though they are better resourced, they're still working in resource constrained settings. And so they lack for equipment, medication, and blood. They deal with really complicated cases that requires careful coordination and decision-making and problem solving. And sometimes the infrastructure doesn't exist for that. And so what happens is that even though mortality rates overall in the country have significantly dropped, the mortality rates in these hospitals are higher than the national average. And so our work over the last decade has been to concentrate on these hospitals to try and think about how do we implement programs, not just clinical programs, but how do we begin to improve the service delivery processes? How do we begin to improve the systems in these facilities so that we can equip them to be able to provide better care to these sick mothers? The work that we have done has been a collaboration between a large number of organizations, and I will talk about some of these organizations later. But the two organizations that our role in the School of Public Health at UNC has been to be the implementation science specialists and evaluation partners for this work. The implementing partners on the ground, there are two large organizations that have been the primary the organizations that have been doing the implementation path, which is a large NGO that many of you might know about. And then our close partners is a North Carolina-based NGO called Cadre. Cadre is an organization that has faculty from Wake Forest, Duke at UNC, as well as partners in Ghana and a variety of other countries. And they are dedicated to improving the quality of maternal care. And finally, our close partners in this process over the last decade has been Ghana Health Service. A lot of the work that we've been doing has been in direct partnership with them. They have led a lot of the work that I'm going to be talking about today. And without their dedication to this work, none of what I'm going to talk about would have been possible. So I'm going to step back a little bit and kind of give some broader context for what I'm going to talk about, and then we'll come back into the projects themselves. So I wanted to kind of start about the talk. Today's talk is about using theory to guide implementation processes. One of the, as implementation sciences continue to evolve as a discipline, and as more and more people have begun to learn about implementation science, one of the critiques that has been leveled against the field is that it is not yet systematic and rigorous enough. That's still the difference between the science of implementation and just doing implementation in practice-based settings is still relatively weak. And that there isn't a whole lot of, we don't quite still understand how implementation works. We still don't understand the mechanisms by which successful implementation strategies result in outcomes. And that a lot of effort is simply paid is done on just implementing rather than stepping back and thinking about the science of implementation. So theory, so there's been a lot of debate about using theory to better drive the process of implementation. And so when I talk about theory, what do we mean? The definition of theory is that's an ordered set of assumptions about behaviors or structures. And when I think about theory, there are two things that come to mind. First, that it needs to be generalizable. So as I am beginning to work with theories of implementation, the objective is to be able to come up with come up with a set of principles that we think broadly can be applied across a wide variety of settings. Understanding that implementation science is inherently context dependent, and therefore it is not as though we're going to be thinking about an implementation theory like Newton's laws of motion that apply anywhere in the world. We do need to be paying attention to context, but we also need to be able to say, here are some general things that we know that work. So being able to use theory well, or being able to develop a good theory, is to be able to come up with something that allows us to have a set of generalizable principles. The second thing that I think about when I think about theory is that it should have explanatory value. We should be able to predict something. And when I say explanatory value, this is where we think about mechanisms. What if I have a particular implementation strategy? So let's say I'm using audit and feedback, or I'm using facilitation, or I'm using coaching and mentoring. I need to be able to understand how these processes, how does audit and feedback, how does coaching and mentoring result in better outcomes? And so if I can, as part of my implementation work, begin to develop these theories that allows me to do these, to both kind of have general principles, as well as being able to come up with some understanding of how to explain how implementation works, then I have moved the field forward from just mere implementation to implementation science. And so that's kind of the general framework within which we have been approaching our work. In general, this work in the overall field of implementation science is still in its infancy. And this is a recent paper by Laura Damschroeder, where she says the science of implementation is relatively young, and therefore without the benefit of long decades of research necessary to establish widely accepted models of change or broadly established generalized theories. So as I said earlier, we don't really have a whole lot, except for one or two theories, we really don't have a body of theories that we can refer to that are implementation theories that researchers and practitioners can use. What exists in implementation science? Hello? What exists in implementation science is this paper. This is the seminal paper that many of you who are implementation scientists hopefully know about. This is the paper by Per Nielsen, who developed 5 or 6 years ago this taxonomy of theories. And he categorized implementation theories into these 3 groups: models, theories, and frameworks. Theories themselves, as I said earlier, are kind of the most rigorous of these 3 groups because they have both generalizability and explanatory value. Models are simplifications of real life phenomena, and they help to describe phenomena, but they don't necessarily have kind of explanatory or predictive characteristics. And frameworks are essentially categories. There are ways in which you can take, so many of you have probably used the CIFAR consolidated framework implementation research, and it allows you to be able to take a data and put them into different categories. And certainly in implementation science, we have not yet been able to distinguish between models, theories, and frameworks. These terms are used interchangeably, or these terms are used together. And so what it has done is therefore resulted in kind of a confusion around, do we really have a theory? Do we have a model? Do we have a framework? Are all of these things the same? And that has resulted, again, in a lack of rigor in the way that we've approached this field. There has been there have been papers, as I've said earlier, about thinking about how to select theories. So this push for using theory-based approaches in implementation research has been around for a few years. This paper by this consortium called the Iceberg Consortium talks about a systematic way of choosing theories. So you need to be thinking about, where does the theory come from? Is it an appropriate theory for your use? You have to examine the meaning of the theory. So what are the concepts that underlie the theory? You want to be thinking about degree of generalizability. Can I use this theory to establish general principles? And so while all of these are kind of great in concept, and obviously we want to keep these in mind, in practice, as I said, we have not actually done this very well in implementation science. And a few years ago, there were results from an international survey that several researchers, including a lot of my colleagues at UNC, did, where they surveyed a variety of implementation scientists from around the world to ask how they selected models, theories, and frameworks. And they came away with the conclusion that the underuse, superficial use, and misuse of theories pose a substantial scientific challenge for implementation science. So all this to say that the field, it's because the field is young, because there is not a whole lot of kind of embedded knowledge about about kind of theories that work. We're very much kind of very much in the experimental stage of trying to think about how to use theories. And what also makes this particularly complex within the field of implementation science is that most of the interventions that we work on, field-based interventions, are complex interventions. Complex interventions have been defined by the Medical Research Council of the UK as interventions that have multiple interacting components that are context dependent. And so whether we think about maternal health in Ghana, or whether we think about mental health in India, or whether we think about work and non-communicable diseases in the US, all of these programs that we're thinking about might have multiple interventions. They may have biomedical interventions, they may have psychosocial interventions, they may have structural interventions. These interventions work together in complex ways, and interact with settings and environments in complex ways. And therefore, being able to say that there is a single grand theory becomes difficult. However, the Medical Research Council has talked about the need for theory development for complex interventions, because, as I said earlier, without developing a theory, you don't have a science. You don't have a systematic way of thinking about how to approach these complex issues. And so the Medical Research Council has said the difference between the theory development in complex interventions relative to theory development, perhaps if you have a single kind of a physiological phenomenon for which you have a biomedical intervention, is that theory development needs to be done in an iterative way. It needs to be done in combination with the people on the ground. It has to be a collaborative process where you develop some initial theories, you test whether these theories work. Based upon the results that you're getting, you might refine your theories. And so this general process of kind of iterative theory development for complex interventions has been used in global mental health, for example, to think about the theory of change approach to theory development. Theory of change, for those of you who have worked in program planning, is essentially a way of engaging stakeholders in thinking about a process by which outcomes are achieved. So theory of change says, what is my final outcome? And what are the intermediate outcomes that I need to have in place in order for me to achieve the final outcome? what are the interventions that I need to have at various levels so that I can achieve the intermediate outcomes, and what might be the assumptions that I need to make around the achievement of these outcomes. So essentially, a theory of change is a collaborative process where we are predicting the steps that need to take place along the way in order for me to achieve my outcome. And theory of change works and is a effective tool for these kinds of complex interventions because they are developed with people on the ground. They are bottom-up theories. They reflect the realities of the particular context on the ground, and they can be used as a starting point for systematic development of interventions. They can be tested over time and they can be refined over time. And so over the past few years, there has been literature around using this theory of change approach for developing interventions. This particular paper reflects work that was done in global mental health about maybe five or 6 years ago, where in multiple countries, the researchers worked with the local government to organize these theory of change workshops. And these theory of change workshops helped the research teams to better understand how to deliver mental health services through primary healthcare systems in each of these countries. What we have done in this work in Ghana that I'm going to talk about is we have taken this theory of change approach, and instead of using it for intervention development, we have begun to use it for development of implementation strategies. So we are using the same kind of theory of change approach, same as a bottom-up approach that we have used in collaboration with the Ghana Health Service. And we are using it to be able to develop implementation theories. And that's what I'm going to be talking about in the second half of my talk. There are two general principles that we have been using as we're developing theory of change. The first is that it is not a static theory. That's what you'll see as I talk about the work that we've done in Ghana over the last decade, how we started, what our initial assumptions were, what our theories looked like at the beginning, and how they evolved over time. And the second piece is that ultimately, for it to be a theory, it must be subject to empirical validation. We need to be able to say, is the theory working? And what I'm going to talk about is what kind of evaluation methods we're beginning to put in place that allows us to be able to validate the theory. We don't have all of the answers yet. As I said when I began this conversation, this is very much a work in progress. But what we're hoping to do is as our knowledge evolves, we're hoping to be able to build a body of evidence that allows us to be able to draw some general conclusions about the implementation process from these theories. What I'm going to do is I'm going to stop here. So this is where I'm going to switch my presentation from talking in general about theory to the application of theories within the context of maternal health in Ghana. But before I do that, I wanted to stop and ask if anybody had any questions that I could answer. Maybe we'll take a minute or two to have some discussion, and then I have probably another 15 minutes or so for presentation. So I'm happy to stop here and take questions.
Rohit, this is Ramana. Can you hear me?
Yes, I can.
Okay, nice to see you. I have a question about implementation science and design thinking. My question is really around, I know one of the things you said was for implementation science, you want to go test and iterate. Would you say that design thinking, like the phase of specifically ideation, such as having a problem statement, coming up with the solutions, and then prototyping and piloting is a good approach to do that? What is the best approach to go about doing that? Or is it more of a PDSA like it in quality improvement?
Yeah, I think it depends on how big your problem is. I mean, if you're thinking about innovations from the ground up and you're thinking about inventing something that doesn't exist, bringing design methods so that you can ideate would be helpful. If you already have systems in place and you're thinking about improvements to the system, then quality improvement type methods are probably useful. But in any instance, you have to be able to think about how do I make it work in my setting. So this kind of iteration around initially coming up with a theory or an intervention and being able to iterate to see how it works is a general method that applies across a wide variety of different, whether you're thinking about implementation or design or quality improvement. This idea of iteration and iterative adaptation is something that we would use across all of those different methodologies.
Okay, great. Thank you so much.
Rohit, this is Moss Blackman. Thank you for this presentation. I just have a quick question for you. As I listen to this, and as you may recall, I come at this from a very different set of issues and fields, and particularly with dealing more with theory of change and strategic management. I'm curious, as you're going through this, if you could just make a couple of comments about the epistemology underlying this, because one of the general discussion about theory really is no different than the general discussion of theory that you would have in any of the social sciences. But the epistemology that underlies implementation science is significantly different, particularly from some form of theory that would be developed in line with general science, positivism or neo-positivism. And what you're describing is clearly different than neo-positivism. So I'm just wondering if you, because to me, if you don't understand the epistemology, it's very difficult to know what you're doing with the theory.
So how about if I talk about our approach, and perhaps we can come back and have that discussion so that I am clear, that I kind of understand the, what you would want me to be talking about. So let me talk about how we have approached this, and perhaps we can come back and discuss that at the end of the presentation.
Great, thank you.
Okay, so as I said, one of our partners in this enterprise has been the Ghana Health Service, and a lot of the work that we have done has been in collaboration with them, in working with their frontline staff to help identify what might be an appropriate theory for the work that we have done. And I'm going to talk about this work in 3 phases. Our first phase was where when we began this work in a single hospital setting. And this was this is Ghana, Greater Accra Regional Hospital. It's the largest hospital in Ghana. It has the highest volumes. And we began with a program called Pepsi, Making Every Baby Count. And the program was a national program. The program had a set of well-known evidence-based interventions that were deployed nationwide. So these 3 interventions that you see on the right-hand side, helping babies breathe, essential care for every baby, and infection prevention, are a set of standard packages of care that were implemented across the country. As our team, so the partners that I mentioned earlier and Ghana Health Service looked at the implementation of Pepsi in the tertiary hospitals in Greater Accra Regional Hospital, it became apparent that because of the complexity of care in these facilities, and because of the higher risk of mothers who came into these facilities, there needed to be a program of care that was more sophisticated than the 3 interventions that I mentioned earlier. So on this slide, you see the 3 interventions in red with the red arrows. And what became, in conversations with Ghana Health Service, what became apparent was that these three interventions needed to be wrapped around a set of more advanced clinical care modules. So things about how do you do obstetric triage? How do you provide prompt cesarean sections? How do you take care of mothers who are recovering after their cesareans? And so the partners that we work with created these advanced clinical care modules. But it became apparent that just developing and training the staff on these clinical care modules is not enough, because these clinical care modules need to be embedded and implemented appropriately within the systems of care, within the delivery systems in these facilities. And so we worked with the local, the frontline staff to identify what the barriers were to achieving outcomes. And as a result of these conversations, we identified, we did an audit of mortalities in the facility, and we're able to kind of categorize. So here's where we think about, when we think about models, theories, and frameworks, without necessarily using an implementation science framework. We identified and categorized the reasons for mortality into three basic groups. There is the clinical, the lack of clinical training. And as I said earlier, so there are some advanced care modules training that was needed. But there were two other sources that we identified that contributed to maternal mortality. One was that there are operational issues. So service delivery processes don't work. For example, the equipment, the kinds of equipment that are needed are not always available, not always working. Oxygen and supplies are not always available. There are significant delays in transferring mothers from the ward to the OR for a C-section. And so it became apparent that there needs to be a way of strengthening the operational processes through which care was offered. And the third piece where gaps were discovered were in, and we're using this word leadership broadly, but this is in decision-making, in authorities, in agency, in communications, and a variety of kind of human processes through which care was delivered. And so based upon this, these conversations, we created our first theory. So this is what we call the Pepsi 1 theory of change. It was fairly straightforward. It basically built from the ground up this idea that if we had change agents, if we had people who could drive change, and we built the capacity of these change agents to do three different things. Obviously, to be able to deliver high quality clinical care, but also to be able to have quality improvement capacity so that they could improve their service delivery processes. And we built this leadership capacity around better decision-making, better accountability, better communications. Then the theory was that as a result, we would be able to build a set of improvement projects at the ward level and across the departments that would help us to close clinical operational leadership gaps, and that would allow us to be able to reduce maternal and neonatal mortality and stillbirth. So this is a bottom-up theory that came from conversations with the local staff. We implemented this theory, and we had spectacular results. So what you see, it's a little bit difficult to kind of read this chart, but what you're seeing here is that in the 5 years during which this program was implemented in Ghana from 2005 to 2009, the volumes went up significantly from 2,971 to 8,230. But at the same time, if you see the table at the bottom, the case fatality rate associated with the two largest cases, the largest reasons for mortality, hypertension and hemorrhage, dropped significantly. So clearly something was working, but that's actually not enough, because as I said earlier, part of what we want to be thinking about with the theory is we want it to be able to have some explanatory power. We want it to be able to have some ability to be able to generalize across settings. And this theory, other than the fact that we hypothesized that if we built some of this capacity, we would get some results, it doesn't necessarily have any more ability to explain anything beyond that. We don't, for example, know the mechanisms by which building these capacities has resulted in outcomes. But it gave us the sense that some of what we were thinking about is maybe the right, we have the right ingredients for achieving outcomes. And so this allowed us to be able to refine our theory as we went forward. And we did that in a very specific context. So one of the interventions that came out of this initial work that we did in Ghana was an obstetric triage program. It's being able to identify who the highest risk mothers were, because of course it's a resource constrained setting. there are priorities that and therefore being able to prioritize the mothers that need the greatest care and being able to redirect them through pathways of care where they could get the assistance that they need in the shortest possible time was something that was that we discovered was really important. And so one of the interventions that came as a result of this initial work in Ghana was an obstetric triage intervention where the mothers who came into the facility, rather than just coming into the ward and then being seen on a first come, first served basis, were rapidly triaged, were banded with red, yellow, and green bands that reflected their level of risk. And then they were sent down different care pathways depending upon their level of risk. And the question was, how quickly could we do that? And what this graph shows, over 5 phases of implementation of the triage program at the Greater Accra Regional Hospital, we began initially where in phase 1, where you can see which is the purple the purple graph all the way at the bottom, roughly 15% of 50% of the mothers were seen about 45 minutes after they arrived. By the time we had completed this program, which is phase 5, almost 100% of the mothers were seen and triaged within the first 15 minutes. So this was a significant improvement in being able to identify who needed the fastest care. And so this particular intervention across a suite of interventions that we undertook became something that we think that Ghana Health Service wanted rapidly to scale up across multiple facilities because it was seen as something that was really important. So we got a grant from Grand Challenges Canada. It was part of the Saving Lives at Birth. It was a competitive award for innovations, and we got an award to be able to scale up the obstetric triage program in multiple referral hospitals in Ghana, across 6 hospitals in Ghana. This project was supposed to have ended in 2020 because of COVID. It has been delayed and is still in progress. But what it allowed us to do is it allowed us to be able to develop a more sophisticated theory of change than we had before. And we developed a theory that was much more strongly grounded in the principles of implementation science than the original theory, which essentially was a hypothesis that came from our conversations with local leaders. The second theory is still based upon our conversations with Ghana Health Service and frontline staff. But what we have done in the second theory is that we have taken the original theory that existed in one facility and we have expanded it across multiple facilities. So what this theory looks like is it has 3 components, and the green component in the middle is the within facility theory. So what the within facility theory says is that some of the earlier elements that we had using champions and change agents, we've still maintained that. But what we've done is we have built a more sophisticated theory that says, what is it that these champions do? Because in the initial theory, we had the champions we're training them in quality improvement and they do quality improvement related work. What we've done here is we have now begun to elaborate on the theory and say what the champions are actually going to do is they're going to support the implementation process by a mechanism of monitoring. They're going to routinely monitor the process of implementation, and they are going to identify, working in collaboration with their staff, barriers to implementation, and then they're going to use these plan, do, study, act cycles, the PDSA cycles that Romana talked about earlier, to be able to test different solutions to address implementation barriers. So the difference between the first theory of change and this theory is that this theory now we have taken what was a general principle. You have to be able to use quality improvement methods to improve, and made it a little bit more specific that says, here is how you're going to be using your QI methods to address specifically identified implementation barriers. So that's one adaptation enhancement that we did to the theory. The other enhancements to this theory is that we've expanded this within facility theory now to have a across facility because we have moved from 1 facilities to 6 facilities. So we have moved it from within facility theory to an across facility theory. And then we have also have a component of the theory that engages the health system as a whole. So basically the idea here is that within the facilities, there is a well-established process that the change agents, the clinical champions follow. And then once, and this process gets replicated across each of the different facilities. Once we have understood what works within each of these facilities, what you see on the red boxes on the left is that these then can be shared across shared with other facilities. So there's an explicit process of knowledge sharing that gets built in. And the theory says by being able to take good practices from one facilities and being able to share it with other facilities accelerates the process of knowledge and accelerates the strategies that I can use to reduce barriers to implementation. And then on the right-hand side, what we have said is that all of this cannot take place without a engagement of the health system as a whole, without the engagement of the leadership of the health system. And so we have created, the theory says if you create an advisory group which consists of senior leadership of Ghana Health Service, and you have people who are change agents within the facilities embedded in that national group. The national group then allows for policies to change so that certain things that need to happen to make sure that you have the right people at the right facilities at the right time. You can work with the national group to be able to advance these policies that makes our implementation more sustainable. So as you can see, what we've done is we've taken some of the elements of the theory that we have learned from our previous work. We have added other components to this theory in conversation with Ghana Health Service and created this next level of theory. And well, unlike what we did earlier on, because now we have begun to learn a little bit more about how to implement, we have created around this theory of change a fairly robust evaluation structure, a process evaluation structure. So without kind of going into a lot of detail on this page, this shows all of the different mechanisms that we're using for evaluation. What data do we get? So it's a mixed methods evaluation approach. And as you can see in the second column, we have within facility, across facility, and system level system level data that we're collecting to evaluate our theory of change. And as I said earlier, part of what we want to be able to do is we want to be able to understand a little better how some of these mechanisms of change work. This evaluation work is very much in progress, but what we're hoping is that we're going to learn a little bit more deeply about how the implementation strategies that we put in place are working that allows us to be able to refine our theory as we go forward. And so that has brought us to where we are now, where we have funding from the Children's Investment Fund Foundation to start a 4-year project that has just started this year to take the work that we have done in the earlier part of this project, which is system strengthening at an institutional level, and to be able to scale that up, to be able to replicate that across multiple facilities in Ghana. So now we're going to be working on 1 facility, working in 4 facilities to bring the same kind of system strengthening model that we had at Greater Accra Regional Hospital. But now that we are able to do this with a greater understanding of how to do implementation, because we have learned over the last few years. And what we have begun to do is we've begun to use a model that we're calling the model for implementation and improvement. The idea is that while in Greater Accra Regional Hospital, when we first started this work, we were somewhat unsystematic about thinking about what kind of improvements needed to take place. We just had quality improvement teams that developed these system strengthening interventions, but we didn't know how well they were implemented. We didn't know what needed to happen to implement them. But now we're going to approach this in a much more systematic way. What this model for improvement implementation says is that we want to think in a systematic way about how to prioritize system improvements that need to happen. We need also to be able to understand what the barriers to implementation of these system improvements are. And we need to have this mechanism of this plan, do, study, act cycle, of testing both the system improvements and the factors that affect that implementation together, so that when we are done with this work, we are able to come up with a set of local interventions, local innovations that strengthen the system, but we also have a set of strategies that make sure that these innovations get implemented well. And so in order to achieve that, we have a kind of a new theory of change. This is a enhancement of what I showed earlier, and I'm not going to talk about this in a whole lot of detail. But basically, what we have begun to do as our theory has advanced is we have begun to recognize that it is not enough just to be able to think about quality improvement training in general. We have to be able to break our quality improvement training into the kind of training that is needed in order for us to be able to develop local innovations. And we have to be able to provide training on how do we implement these innovations. In addition, the things that we need to be able to do is it's not just enough to identify change agents and give them all the same training. We have to be able to identify different cadres of change agents. So what you see here on the left-hand side in the purple boxes are the different levels of change agents that we've identified. So we have within each of these facilities, we have hospital and unit leaders. These are the people who are providing the leadership to the institution as a whole, and they need to be trained and supported in particular ways. Then we have the mid-level cadre. These are the implementation and the quality improvement coaches who are going to be working with the frontline staff in helping them to think about local innovations and helping them to implement these innovations. And then we have the clinical champions. These are the frontline staff who actually are going to be responsible for making sure the implementation actually happens. So what we have done is we've taken what we have learned from our previous theories and we've expanded it out to understand how to develop more targeted, more targeted both support strategies and training strategies for different cadres of staff. And this is only the theory of change at the facility level. We are building around this the cross-facility and the health systems theory. So as you can see, as we have learned from the implementation experience over the years, our theory is also getting more sophisticated. Our theory is getting more complex. And ultimately what we want to do is we are developing the evaluation structure around this theory of change. So this has just started this year. This is the work that we'll be doing over the next 3 or 4 years. And our goal is to do what I said earlier, to use theory, to use this theory, first of all, to make sure that it is contextually appropriate. So this is not a theory that is being developed outside of context. We're still developing it in very much within the context of the environment that you're working in. But what we hope to be able to do at the end of this is to be able to come up with 4 advanced maternal and neonatal care in Ghana, to be able to say, here is how you implement programs that advance maternal and neonatal care in Ghana. Here are the things that we know work. Here is how you set up a structure within the facilities that we know to be successful. And we know that these will be successful because these are the mechanisms by which our implementation approaches work to be able to drive outcomes. And that allows us to get to where the field needs to go. This is a paper that was published last year around this. It's a systematic review of studies examining mechanisms of implementation in health. How does implementation actually result in outcomes? And as the authors say, we are not there yet. To move the field forward, there is need for greater precision to achieve conceptual clarity. We need to generate testable hypotheses about how and why variables are related. We need to be able to understand the relationship between proximal outcomes and health outcomes. And none of these are really kind of known very well in the field right now. And so what we're hoping is through our kind of sequential and kind of more and more sophisticated theory building approach, through our kind of overlay on learning, on using what we have learned to build the next generation of theory, and to be able to bring some of the results from our robust evaluation to bear to help us better understand how to do implementation. We will strengthen both kind of the use of theory in implementation in Ghana, but will also improve generalizable knowledge about how implementation science works in general. So that was, I know that I covered a lot in a relatively short time, but I hope it kind of gave you a general sense of the process we've been using, how we are beginning to bring a little bit more system and structure into kind of the practice of implementation, and how we're beginning to think about theory development for implementation evaluation. Thank you very much. And I'm opening it up for questions. And let me stop sharing at this point.
Rohit, there are a few questions in the chat. Are you able to see that, or would you like me to read it out?
Yeah. My question is about the need for theories that bridge the very many and increasing number of implementation science theories. Do we need trans-theoretical theories? Yeah, we have actually, our approach has been essentially trans-theoretical. We have, and I must admit, we have not necessarily done this in a kind of any systematic way. What we have done is we've done some cherry picking because we've needed to do that. And all of my experience has been that people who've been using theories have done this kind of cherry picking. We've looked across the different theories and frameworks to see, to look at things that would be useful for us. So for example, I didn't say this in detail, but our theory of change for the obstetric triage program was based on the interactive systems framework. But then we have overlaid on the interactive systems framework CFR, the consolidated framework for implementation research that we're using for our interviews of implementation barriers and facilitators. And then we're using normalization process theory to be able to look at measures of sustainability. So we have developed our own trans-theoretical approach. And I think that that is needed. There are now tools available for theory selection that have become available, but they're not always kind of user-friendly. So I think kind of a systematic way of thinking about trans-theoretical theory generation and implementation science is much required. We've done it in a more or less ad hoc way. Okay. Yeah, I think the question of pragmatism is a well-suited epistemology. That I think that's exactly right. I think it is, and this is where I come back to kind of thinking about cherry picking. Our approach has been solidly, grounded in to what extent can we be systematic about an approach that works. And works, we have had to think about it in two ways. Not just works for us as an international team, but works for the staff on the ground. So we have specifically both the way we have kind of framed the theory development process, as well as the way we've explained the theory development process has been in a way that is kind of acceptable to the staff on the ground. Which hybrid type design you were using in Ghana and which you recommend? We're not actually using a hybrid type design. This is not a kind of a research study. How do we change the organizational culture within healthcare systems to include community-based organizations at the table? Yeah, I mean, this question is not directly relevant to what I've talked about, but as I said, all of the work that we have done has been in close collaboration with the frontline staff in these facilities. That everything, so the idea of how do we think about these clinical champions and who these clinical champions should be and what their role should be and what kind of training is needed has all been done in participation with the frontline staff. And the more that we have been able to involve them, the more that we have learned from them. And that has allowed us to make our theories more sophisticated. From Ameya, wondering how the theories frameworks account for changing dynamics at a health facility. Yeah, this is a really good question. And in the obstetric triage project that I talked about is having the technical advisory group as an explicit part of our theory has been something that we have used as a way to address the dynamics, the changing dynamics of the health system, especially, as you said, because of COVID, a lot of our implementation has been on hold, and a lot of implementation has been delayed. And using the advisory group explicitly, and what part of our evaluation is to think about how do we use them? What is it that they contribute? How do they need to be constituted? What kind of skill set and leadership levels need to exist that allow us to be able to leverage kind of the appropriate leaders at the appropriate time? That is the piece that we've been, so we have one of our students is doing actually a set of interviews with the technical advisory group to understand how they work. In the new project we've got, in addition to the technical advisory group, we've got a higher level strategic group that we're beginning to form to understand how they can both be they can tactically help us with the changing dynamics, and how they can kind of strategically help us to be good to build the policy infrastructure that will allow for sustainability. From recommendations to research and implementation science team who want to do the same process of refining and deepening their theory of change. What processes work best across time zones? Zoom to get started and dig in. Yeah, we had thought, so one of the learnings from that we've had during the COVID years is actually that our original thought that we needed to be in these countries as often as possible, and that without our presence, without the international team's presence there, things would not move forward, is a fallacy. I think the general advice, what we have learned, is that things are working extremely well with a combination of, and depends on the country. You know, Teresa, you worked in countries that whose infrastructure is not as sophisticated as the infrastructure in Ghana. Now, Ghana internet works well. All of the frontline staff have smartphones, and so it has actually made it relatively easy. We have done, and I didn't talk a whole lot of detail about the way that we've set up our communication systems. We use WhatsApp a lot. We have multiple WhatsApp groups. We have built for data collection a Google Forms based data sheets that automatically populate dashboards, so people on the ground can populate the data as they're monitoring, and it becomes available to everybody. And we are using Zoom calling effectively. So for my recommendations for implementation science teams who want to do the same process is begin to look at kind of what technology people are using. WhatsApp seems to be ubiquitous. Begin to build connections using WhatsApp and begin to build social connections, and that then allows for the kind of the creation of platforms from that you can begin to use for more sophisticated data for data collection.
Thank you.
The last question about the legacy of racism. Yeah, thank you for that question. That's a really important question. And this is something that we talk about every day. The intentional transfer of agency for this work from the international team to the local team is something that is really critical. When we talk about capacity building, we use that word carefully because it is not as though somebody has kind of expert capacity that then needs to be built. So this process of learning together is something that we hold really important, and being able to center the knowledge from in the facilities themselves and amongst the facility staff, and not necessarily think about external knowledge that we bring to the table, is something that we have been thinking about very carefully. So that doesn't necessarily mean that overnight we're able to kind of disrupt the structures of racism. Also doesn't mean that we're able to disrupt existing hierarchical power structures that already are inherent in these systems. But by being able to be respectful, have the right kind of humility, understand that wisdom doesn't sit with us, and that this is a learning process that where we have as much learned as we have to provide, is something that we hold very important. So thank you for asking that question. What do you think of identifying and measuring contextual factors that affect the implementation of programs' impact on outcome? Yes, I think that's really important. A lot of our work right now, just because we were trying to get the programs implemented within the facilities, has been measuring facility context. We are beginning to think about how the outer setting as a whole and governance structures at Ghana Health Service will impact program implementation in general. And it's as the obstetric triage program comes to an end this year, and as it is being taken over by Ghana Health Service, and as they are thinking about spreading it beyond the facilities where we have implemented it across the country, these general questions of how we want to be able to build how kind of external policies and political systems affect that scale up and sustainability is something that we're beginning to look at. So one of our students is starting a research program that is working with the senior leadership of Ghana Health Service to identify some of the external factors. Thank you for those questions. I recognize that I read them quickly. I'm hoping I actually answered them, but please feel free to send me email if you have any other questions.
Great. Thank you so much, Rohit, for such a good session. And I thank everyone for their amazing questions. It was a really, I think, rich discussion. And we have recorded the session, and we will make sure that we get it on our YouTube series so that others who couldn't make it today are able to access it in the future. So once again, thank you so much.
Thank you for inviting me. Have a good day.
Absolutely.
Thank you.
Have a good day, everyone.